Our next presentation is called Everything is Double and Moving from Janet Rucker from New York City.
Good afternoon. Thank you very much for inviting me to participate today. So we're going to stick with the theme of double vision, but we're going to add into the mix a little bit of oscillopsia today, so a subjective sense of visual motion. I have no financial interests or conflicts to disclose. So our patient is a 35-year-old woman. She has double vision, and it's definitely binocular, and it's definitely horizontal, and she reports that it's worse at a distance. She also has this sense of oscillopsia. She really can't clarify for us when she experiences it or which direction it's moving in, but she sees that the world is in motion. She has a very long ophthalmologic history. She has a diagnosis of congenital esotropia. At age 6, she underwent bilateral medial rectus recessions, which were quite successful for a long time until at age 16, she developed recurrent diplopia, had bilateral lateral rectus resections according to the records, and then she had some success with that, had a little residual diplopia for which she wore a prism. Eventually, at age 26, her prism stopped working, and she underwent with a different surgeon now bilateral medial rectus recessions again. So a little bit more from the notes that were available at age 26. She had recurrent diplopia. She definitely, and this was my history with her at the time when she had that surgery at age 26, did not have oscillopsia. And she was given a diagnosis at age 26 of recurrent breakdown of a congenital esotropia and manifest latent nystagmus. So she underwent surgery, which resolved her diplopia. And on the post-surgical note, she had a residual 3-prism diopter esotropia, and there was one sentence in the chart that commented upon her nystagmus that said she had manifest latent nystagmus, worsening on gaze to either side, almost dampening in central gaze. Eventually, her diplopia recurred. She wasn't quite sure when this happened, a few years after surgery, and at age 30, she had the onset of oscillopsia. So for several years, she had persistent diplopia and oscillopsia and sought further consultation, and she brought her parents with her to the examination, and neither the patient nor the parents had ever been aware of nystagmus prior to age of 26. On review of systems, fairly unremarkable. She thought maybe her balance wasn't as good for the last few years, but she attributed that to her oscillopsia. On examination, her visual acuity was 20/20. She had normal color vision, pupils, visual fields, and fundus exam, full eye movement range. She had a comitant 10-prism diopter esotropia. She preferred fixating with her right eye, and she had a little bit of difficulty with heel-toe or tandem gait. So I'll let you just first watch the video through as if you're examining the patient. Okay, so you did your examination. Now we'll have an audience response question. What would you do next? Repeat strabismus surgery for diplopia due to congenital esotropia, thymine replacement for Wernicke encephalopathy, MRI of the brain to assess the cerebellum, or a medication trial for oscillopsia from manifest latent nystagmus. So go ahead and vote. So everybody wants an MRI scan. All right, so let's go back Now to the discussion, and I'll ask the panel to first kind of walk the audience through the feature of the nystagmus. The video is going to play on loop here, and then also discuss what you would do with this patient, what you would be thinking about. And you'll notice I have a second little clip down below. At some point, we can watch that video clip to contrast with this patient as well.
Well, first of all, if it were latent nystagmus, the eyes would be beating towards the uncovered eye, so that it's beating towards the covered eye, so that I wouldn't think this is latent nystagmus, number one. And then in down gaze, there's downbeat nystagmus.
Yeah, I mean, this is gaze-evoked nystagmus. She has right beating in right gaze, left beating in left gaze, and down beating in down gaze. You didn't show us up gaze, but that to me is a central vestibular nystagmus of the cerebellum and its pathways within the brainstem.
And how about right here in the video? She does left gaze and then looks straight ahead.
I have to admit, initially when you were presenting this patient, I thought this was going to be, just from the history before you showed the video, was a congenital pattern of somebody with congenital esotropia, congenital nystagmus, and dissociated vertical deviation. I thought you were going to present that with a little bit of oscillopsia, but this, again, this video doesn't show that. I agree with Nancy, it looks like gaze-evoked nystagmus.
And so gaze-evoked nystagmus, right gaze, left gaze, a little bit in down gaze as well. And let's just let the video play through again and watch after left gaze. Maybe you can comment. She does develop some nystagmus in central position.
Right. It's right beating, so rebound.
Yeah, so what would you like to do with this patient? Obviously, the audience wants MRI. That's going to be our first choice. But in addition to the MRI scan, would you get any other testing or comment upon maybe the differential at this point?
Well,
You can-
you've localized to the cerebellum.
Yeah, I
and
agree.
its
I just want to
connection.
make a point to the audience about the nystagmus. If you cover one eye in primary and there's no nystagmus, it's pretty hard to call that latent nystagmus. Manifest latent means it's present with both eyes open, but there is some occlusive event, either from amblyopia or whatever, some other cause of decreased vision in one eye. So you can't really call this even manifest latent nystagmus. So this is indeed gaze evoked with rebound.
So to be fair, she did, to the ophthalmologist who saw her and did her strabismus surgery at 26, we didn't have a lot of details about what her nystagmus looked like at that point. She definitely did have nystagmus at times in central position, and even then it could perhaps be persistent when she would cover one eye. So that horizontal piece of it could be a little confusing, and we don't know if she had downbeat nystagmus at the time when she was seen when she was 26, or if that developed later on. So that's
But, for instance, if she's looking to the right, she's got a right beating nystagmus, you cover the left eye, you're going to see, we're beating away from the covered eye. You could misinterpret that as latent nystagmus, but that's what you should be able to see in primary, not a dampening in primary.
So I think that's a perfect segue to watch this other video, just for contrasting examinations, and you can comment, maybe Mike, on what you were talking about.
Here with, there's there, we're beating away from the covered eye in primary, and there's obviously an esotropia there as well. So, the other name for latent nystagmus is fusion maldevelopment nystagmus, and it stems from lack of normal binocular input in the critical period of visual development.
Okay, so the final diagnosis in this patient was indeed revealed by her MRI scan. She had a very large Chiari-1 malformation. I'd like to ask the panel at this point to comment further upon her esotropia and what you think the origin of her esotropia
I
is.
assume the near deviation was nothing. The
She
10
did not have a near deviation.
Yeah, so, that's, divergence, insufficiency, esotropia is a classic presentation of Chiari-1 malformation. In fact, I think there's some question as to whether she ever really had congenital esotropia. This can certainly onset in the first decade of life. And, she's also complaining of diplopia along the way, which is atypical for people with infantile esotropia.
So that was the question, whether she indeed had a congenital esotropia or whether she had a so-called cerebellar esotropia from increased convergence tone. And she had 3 different kinds of nystagmus, really. She had the gaze-evoked nystagmus, right beat and right gaze, left beat and left gaze. Sometimes they'll have upbeat and up gaze, which she did not have. Downbeat and down gaze is often a separate downbeat nystagmus, but in her case, we didn't see any in central position, so perhaps part of the gaze-evoked. And then she had that rebound nystagmus. After looking to the left, she developed some right beat nystagmus transiently in central position. And she also had the gait imbalance. So a 35-year-old woman certainly should be able to heel-toe walk in the clinic without any difficulty, and she had some difficulty with that. So she did indeed undergo a decompression for this Chiari malformation, and she had a really nice outcome with resolution of her oscillopsia and gradual improvement in her gait imbalance.
Janet, can you show the Chiari for the audience with the arrow?
Sure. So the Chiari malformation is right here, where you see the tonsils of the cerebellum that are dipping down through the cervical medullary junction here. You can look at a line that might be drawn between these 2 points, and the cerebellar tonsils should be above that line, and in her case, they're substantially below the line.
Janet, did her esotropia get better after the decompression?
It did not.
Okay.
She still had diplopia and had a similar-sized esotropia over a few visits post-op.
And in retrospect, did she have headaches or Valsalva-induced symptomatology of any sort?
She didn't. She had no headache history at all. So a few take-home points from this case. Manifest latent nystagmus can be tricky. It's usually associated with a congenital esotropia. The nystagmus beats towards the fixating eye. And in abduction, when they look eccentrically, it can mimic cerebellar nystagmus because it'll be right beat and right gaze often and left beat and left gaze often. But the trick is, if you cover either the fixating eye or the abducting eye, you will see it reverse direction. And it can also develop later than infancy, and there are some reports of it actually causing oscillopsia, so it can be confusing in some instances. However, we really have concern for posterior fossa process when there's gaze-evoked nystagmus without reversal of direction, especially if there's no nystagmus in central position. And there's usually no horizontal nystagmus in central position unless it's a rebound nystagmus in the opposite direction after eccentric gaze. And lastly, any vertical component to that nystagmus gives you pause to look at the posterior fossa, although a few beats of upbeat have been reported with manifest latent. And other signs of cerebellar dysfunction, such as her impaired tandem gait, may be present on examination. So that's all I have, and I thank you and welcome any other comments from the panel.
This is an interest of mine, this phenomenon of divergence insufficiency from Chiari. And I think, first of all, points out it's really important to have distance and near deviations because there's no way you can make the diagnosis without that. We've reported this several times with improvement of the esotropia after decompression. And we have found that the success rate of the diplopia to improve is much better if they do a duroplasty with the decompression than if not.
Do you ever have them get better enough that they're now exo?
No.
Because you had operated on them? No.
No, we're talking about the decompression as the primary treatment for the esotropia.
Because in this case, she's had multiple surgeries for an esotropia, and it would have been very interesting if she ended up.
There were a couple of questions from the audience regarding this whole issue of the divergence excess and what happens in kids. What makes us need to scan a kid with problems like this?
You know, most esotropia in childhood is the same at distance and near, or worse at near than at distance with accommodative tone. If it's worse at distance, there's a high likelihood of finding some posterior fossa abnormality. So, you know, and in fact, I would, you know, anybody under 50, I'd scan for that